All right, it is noon. Let's get started, Joe.
Great. Thank you, KaLynn. Andy, can you hear me okay, right, KaLynn?
I can.
Awesome. Well, hey, first of all, on behalf of Access One and PNC, thank you so much for coming today for our webinar, which is Understanding the Impact of State and Federal Regulations on Revenue Cycle. We really appreciate your time. We know you're busy, so thanks again for being here. My name is Joe Hall. I'm the Vice President with Access One. And really to start, I know both Access One and PNC would like to call out our thoughts are those with you that have been affected by the hurricane here that happened recently. It seems to have an effect quite a bit. So to you and your families, just know our thoughts are with you and we hope everybody is safe. So Access One and PNC have a long history of partnership. We are actually a client of PNC, and we also have a strategic partnership around patient financing solutions. So just a quick second on what we do. So Access One enables RCM teams to help all patients effortlessly pay for care. And we have two solutions where we deliver that. So that is a patient financing platform, as well as a mobile statement and billing tool. PNC has over 30 years of offering solutions and strategic services that are specifically designed for healthcare, including products that are specific for the revenue cycle. So following today's call, if you have any questions on what we do in our products, please reach out and we'll definitely get you more information. So a little bit of housekeeping before we jump in. We will mute all lines just to make sure we have a smooth conversation today. There is the chat function at the top here in Teams. As you have questions, please put those in the chat. We are saving time at the end to address questions and answer those. And then finally, during the registration process, we gave the opportunity for you to indicate if you would like some one-on-one time to discuss your specific needs more. We had several takers on those, and we will be reaching out following this session to get some scheduling done. If following this call, you didn't raise your hand, but you would like to have some one-on-one time, please reach out as well, and we're happy to get that set up for you. So a little bit about our speaker today. So KaLynn Gates is the Chief Commercial Officer and General Counsel for Access One. She is an entrepreneurial lawyer and healthcare evangelist with a mission to make healthcare affordable for all. She brings a unique combination of executive leadership and legal experience to healthcare finance and consumer credit products. I know that she is my boss, so I see it every day. She is active in HFMA as both a board member for the Washington, Alaska chapter, as well as a speaker at many different HFMA events. Finally, she was an American Bar Association speaker alongside the CFPB, which you'll hear more about today at the Winter 2024 meeting. So, KaLynn, I'll turn it over to you.
Thank you so much, Joe. And just want to echo the sentiments, thoughts and prayers with the families that were impacted by the hurricane. You know, Access One is based in the Carolinas. And so we are seeing firsthand, family and friends who have been impacted, as well as we have several clients that are navigating that disaster. So I just echo that sentiment and really appreciate you taking the time to join this conversation about a really important topic. We are in election season, if you happen to miss that. And it's a really important time, and there's a flurry of activity just being, I think, 33 days out from the election. And at Access One, thanks for my background there, Joe. I think I come to the table today with maybe a unique perspective. I have been in the healthcare payments industry for over 10 years, and where I've sat really has been at the intersection of financial regulation as it applies to healthcare payments. And the financial regulators historically have not really got into this space, and that has changed significantly in the past few years. And so, what I hope to bring to you today, although I have never sat in your seat as either a CFO or VP of Rev Cycle, I have sat for over a decade working and speaking with financial regulators, the Consumer Financial Protection Bureau, and a lot of these different types of almost financial regulations. And we're seeing that approach sort of nearing its way into revenue cycle like never before. And so, I'm really looking forward to your perspectives. But what I hope to leave you with today is where I think things are going, putting you on notice of the policies and trends across the country. So as you are leading in your institutions, you can, have an ear about how do I stay in front of these regulations? How am I a leader in the industry? And I think I can say for everybody here, we want to do right by the patients. We want to provide affordable health care. And I think the voices here of our revenue cycle leaders are so important in a complex healthcare system on how we go about that. So I think it's really important as we dive into this conversation to really set the stage of where we're at, because it's really driving all the policy trends. For this first, the stats, this one's thrown out a lot, 220 billion in medical debt. There's a lot of conversation about, is this number accurate? But I think the point is, this is the one that's used. It's the eye-popping stat that is in the federal reports, that is in the media, and is the stat that most folks tie back to when talking about this issue. 15 million Americans have 49 billion in medical debt appearing on their credit reports, which is a huge issue for the Consumer Financial Protection Bureau, which we will speak about later. And 50% of the American public say they cannot pay, that they can pay for medicine or healthcare they need, which is down from 61% in 2022. I'd also be amiss to not mention inflation. It is also another top election issue. People are looking at all of their bills, from groceries to rent, and medical debt and medical care is just one of those other expenses that I think people are having to really look at their entire expenses and decide what care are they going to forego care, or are they going to forego food? And I think that's something that we'd all want to solve for. The perception, healthcare is a top 3 election issue. And so it feels, and I can feel in the media every day or through some sort of policy making, this is a top thing for both state and local uh, policymakers to answer for their constituents. What's interesting is that according to a recent Gallup poll just done last month, U.S. adults still feel that there is not enough attention in this 2024 presidential campaign on healthcare. When you dive a little bit more into those numbers, it's really split. You'd see more of the older generation focused more on prescription drug costs and Medicare, whereas younger generations, when they talk about healthcare, it really is about that access and affordability. And I'd say overarching across all demographics, a concern about the investment in mental health and behavioral health across the country. Further, for the background and the perception, there is a significant amount of nonprofit and active media focus on medical debt. This group is actually fairly small. Is a definite about a dozen folks that are really dominating the news cycle and the news articles, which then are being cited by federal agencies or other policymakers. Um, and really ending up on different panels within this summer. The American Cancer Society Action Network had many of these folks speaking. There are a lot of universities that are speaking and holding panels, and a lot of these same folks have a very tight um, talk track around how they speak around the state of medical debt. And really, the focus of these groups has been disproportionately around a couple things. I think one, highlighting healthcare is complex. And that's really where it starts. And usually focusing on a patient or a situation where, due to the complexity of healthcare, the patient was in a position with usually an exorbitant medical bill and having a challenging time navigating the healthcare system. A lot of times that story is then contrasted with highlighting the revenue line of a lot of our largest healthcare systems across the country, sort of saying this patient had this situation, this health system makes billions of dollars a year, and then really just focusing on, hey, most of that's being targeted in the media, they're nonprofit. There's the charity care aspect, and really focusing on and putting either explicitly or implying, are our nonprofit health systems providing the charity care that they're required to do. I'll note a lot of the folks that we sort of see as repeat in this engagement, many actually do not have revenue cycle experience or have not really been deep into understanding the complexity of the healthcare. Now, their experiences are completely valid. They may have had a poor experience, or may have had a situation or have a family member that occurred. But a lot of what's missing from these conversations is to understand the levers and pulleys and interests and just complexity of how do you put policy suggestions out there without really having a deep understanding of the healthcare ecosystem. Um, and I think that voice you'll see as we get through the federal and state policies is really missing, um, to make sure that these policies match the needs of the healthcare environment. So speaking of that, with all of this background of both the what's really happening in the United States, plus the perception and the pretty active media and nonprofit focus, it's really driving a flurry of policy making, in particular on the state level. And it's creating quite the patchwork of different requirements for health systems to try to navigate. And I'm seeing about um, 5 different themes across the country, that policymakers are focusing on. And the first is absolutely charity care and financial assistance. Going back to what I was saying around health systems, the media focus being a complex healthcare out, a patient having a poor billing experience, and then highlighting usually the size of the health system and the fact that they were nonprofit. Many policymakers are rushing in to trying to be responsive around um, answering this idea that our health systems providing the charity care that they're required to. And we already have that in 501R, right? We already had this charity care requirement. And so what we're seeing here is a level of prescriptiveness around charity care. So we're seeing more requirements for presumptive eligibility. We're seeing more requirements around posting, very specific rules and regulations saying it must be on the website, it must be within the statement, it must be provided at several different entry points or along the billing continuum. seeing that charity care being inserted before a patient can be referred to bad debt. Also seeing some additional reporting requirements for providers around application turnaround times and the amount of applications and screening that they've provided more than they had before. And tacking on to that, then after charity care, a pretty strong focus then on affordability. Now, according to a USC study, 95% of US health systems already were providing some sort of payment plan. But what we're seeing now is actually rules and regulations mandating that health systems provide the availability of payment plans. Now, this probably isn't an issue for many of the folks on the phone. It's what really comes next is the level of specificity that we're seeing in some of these rules around how those payment plans are provided. And we've seen it. We have about a handful of states and a couple we're going to cover today that are actually adding income requirements on the payment plan. So what does that look like? One common theme we're seeing is a payment, the minimum payment for the payment plan cannot exceed a certain percent of the patient's household income. We're also seeing some caps and duration requirements around those payment plans, which is adding a lot of questions for our providers about how to make that scalable. And we'll get into that. Third, bad debt collection practices. If I can sum this up in a sentence, is we are seeing an unprecedented squeeze on the bad debt, medical debt collection industry. There is a significant focus on weakening or removing or making it harder to use traditional tools that bad debt agencies usually use. For example, we'll hit on here in the next section about a trend on limiting or flat out prohibiting the reporting of medical debt to credit rating agencies, limiting the sale of debt or how you can sell debt, requiring, as I mentioned before, additional notices around financial assistance before being able to send a bad debt or requiring additional screening, and a lot of restrictions around any sort of legal asset garnishment protections for folks that are in a legal proceeding for medical debt. And that really leads me into the fourth, more legal protections for patients. So we already, as I mentioned, have, the No Surprises Act and price transparency rules, but we're seeing a lot of states enacting state equivalents and mirroring those rules, and then tacking on to them some prescriptive requirements about how patients can challenge those incorrect bills, whether that be setting rules for response times, setting rules for what the patient may or may not have to provide, what the health system has to provide in terms of the allegation of being incorrectly billed, and then also putting some restrictions about what can happen while that patient is challenging the bills. And really interesting thing that's popping up in New York, and I haven't seen it anywhere else, is there is a concern that's especially from the Consumer Financial Protection Bureau around, we're going to put all these restrictions and patient protections around medical debt, but the minute the patient uses a traditional credit card and they put their medical bill on a credit card, they effectively could be losing some of the protections that they would have otherwise. So if the patient cannot meet their obligations on their traditional credit card, that technically medical debt could be reported against their credit. circumventing sort of the uh, policy and purpose of that the CFPB is focusing on right now. And so there's an interesting approach to tackle that in New York, where adding a disclosure to patients before allowing them to use a credit card to pay off their medical bill. And so that might be a trend we see the as states focus on prohibiting credit reporting with medical debt. And then finally, a theme of a lot of debt relief. There was a package of funds that came out of COVID that a lot of states are using, along with some nonprofits, to retire or forgive large amounts of medical debt. And that really leads me to what I want to focus on first is the backdrop of what's going on a federal level. Um, and there might be an agency on here that you're not usually used to hearing about, and that is the Consumer Financial Protection Bureau. The Consumer Financial Protection Bureau, the CFPB, was born out of the financial crisis. Historically, at that time, they were focused on mortgages, being the financial crisis, a lot of work on student loans and student loan servicers, focused on banks and the stability of banks. Um, Recently, the Consumer Financial Protection Bureau has taken a very big interest in the issue of medical debt. And the CFPB is not your regulator, but whose regulator they are is financial institutions and debt collection. And so what you're seeing is the CFPB coming in, impacting medical debt policy kind of through a backdoor way of by using the regulations and their ability to impact debt collection and what kind of happens afterwards. So the first that recently has occurred is there is a proposed rule to, as I've mentioned, remove medical debt from credit reports. It also adds some additional restrictions on creditors being able to use that information to make credit decisions. The thought here is that the CFPB and the economists they have on staff is that medical debt is not an indicator of a patient's creditworthiness. Um, and there's a lot of healthy debate out there if you want to get engaged with that at the CFPB. But saying that medical debt is just different, saying that it is usually not something you know the cost of, and it is something that is not planned, and therefore it really doesn't determine if a patient defaults on their medical debt. Does that really say something about their ability to their credit worthiness? What will be interesting is will creditors just know that that maybe the credit report is incomplete? Will that change creditor behavior in the future? To be seen. There's a lot of folks talking about this rule and putting a lot of pressure and advocacy against this rule. There's a lot of conversation. Is this the right thing to do? And the accuracy of credit reporting. But I think the thing to know is, regardless of what the federal government does, there are already states that have passed this. California, New York, Connecticut, Minnesota already have passed a similar rule. And so regardless of what happens on the federal level, we're going to probably see this roll out across a multitude of other states. So if your state already has not initiated rulemaking, as something to look out for sure. The second thing that the CFPB has really been focused on is medical credit cards. And the CFPB, is really sort of to focus on the medical credit card industry versus really looking at the entire traditional credit card market. And it's when as Joe mentioned, I've had spent some time with the CFPB back in January. And really the focus here is complaints. The CFPB is driven off complaints and where they need to focus. And there is a significant amount of complaints around deferred interest associated with these cards. What is deferred interest? Deferred interest is, you are given 12 months, for example, to pay off a medical bill on their card at 0%. But if you do not, they will retroactively apply those interest rates as if you never were 0%. Majority of these all of these medical credit cards are what's called non-recourse, meaning that it's the patient defaults that medical credit card company can forward into collections. They're not going back to the health system. So again, that concern around are patients losing their protections, their consumer protections that all those other policies were trying to solve. But also because of these folks are mostly non-recourse, they have to handle that risk of default somehow. And that means cost. And so a lot of times the interest rates are pretty hefty into the 20%. And so you hear these really terrible stories where patients are paying a pretty significant amount when they do not meet this deferred interest time period. In some allegations, they're saying that some of these deferred interest cards are not setting the minimum payment so that the patient will actually pay off in 12 months. So I really encourage, if you're using a non-recourse vendor, to be asking for the terms and conditions, because I think what's advertised sometimes is not exactly what's in the disclosures. And we currently have a letter from the Senate. There's about half a dozen senators that are calling on the CFPB to completely ban deferred interest as a tactic. And so just a word of caution, when you're looking at the product design of medical credit cards. I have included in the resources, Access One actually wrote a comment letter to the Consumer Financial Protection Bureau saying there is a better way. So, of course, a plug for our model in that, this is why we designed our plan the way that we did, to allow patients to receive financial assistance and not be receiving punitive interest, all of those things. So, encourage you to take a look at that. The CFPB realizes it's got restricted jurisdictions on making an impact here for medical debt, and so we do see them partnering with the Department of Treasury and the Department of Health and Human Services. So folks who are going to have regulations over like your 501(r) compliance and your Medicaid, Medicare compliance, and so the IRS did have a goal to do 34 audits on tax-exempt hospitals this year. I have not seen the progress, if they've made any progress or if that really came through, but just continues to signal that the federal government is going to be very active in this space, and to stay vigilant and aware. Now, with that as a backdrop, I think the thing you'll notice is the federal focus is very much, as I said, on the back end. There's a lot of focus about what happens to medical debt in collections or on the back end. And so what you're seeing is a lot of states coming in and trying to solve for the rest. At the beginning, I said a lot of focus on charity care, financial assistance. And so policymakers are responding in a variety of ways. And Maryland, North Carolina, and Florida, why these three? I think what you're going to see is a really interesting compare and contrast about how these rules are getting created, the visibility on the reason why, and really that helping us inform how do we navigate this regulatory environment? So the first that I'm going to hit on here is Florida. Um, Florida is most recently introduced and passed House Bill 7089 on healthcare expenses. This was a bipartisan bill. It was signed by Governor DeSantis, who has been focusing on an entire package of what is being called the Live Healthy bills. Uh, these bills range from investing in innovation in healthcare to focusing on mental health and behavioral health. But the one that really applies to revenue cycle is this healthcare expenses um, rule. And what's interesting, or what's normal, I guess I should say, around House Bill 7089 is it was passed through the House and the Florida Senate. And so when you pass bills through in this way, or you make laws, I should say, in this way, you get a lot of access to public information. So you can go, and I've included in the resources for you you can click right into these bills and and analysis. And in there, you can see the conversation. You can see the meeting minutes. You can see the bill rationale and where our policymakers are coming from, um, and seeing the push and pull to make a strong healthcare policy. And that's really important for us as we're navigating how to implement these rules, because you can understand the intent of the policymakers, which then helps you when you're in a gray area of trying to implement, any of these rules below. So what was House Bill 7089? It's sort of in two groups. The first is these top three, focused on transparency and basically what we saw in the federal price transparency rules and the No Surprises Act. So really, for healthcare providers, I hope this wasn't a surprise for you, because really this mirrors federal law. Um, and what is happening here? Why would they do that? I think there's conversation now. Are health systems uh, implementing price transparency rules at the speed that folks want to see? And so what this is doing by enacting this into Florida statute, it is giving Florida agencies and the Attorney General more power for oversight and enforcement. So something to note there, that as of May 2024, there is some more enforcement and oversight around those top three. The second thing we're seeing in Florida really is around medical debt. And, as I've mentioned, right here in Florida, you're seeing that policymakers do not want any extraordinary collection activity before determining financial assistance. So you're probably going to see and providers in Florida adding an additional financial assistance screening before bad debt. Um, and adding more tools, because here to my last 2 points is really some traditional bad debt collection tactics were weakened. Um, Writing off that theme that we've talked about already is this Florida rule reduced the statute of limitations. So the time that you have to take action over a medical debt was narrowed from 5 to 3 years. And then it also exempted the cars, houses, and at certain levels from being garnished or having impact from any sort of legal action around medical debt. And so what do you really do with this? I think it's just a continued theme that we're seeing on the federal government, that traditional debt collection practices are going to continue to be more expensive and more difficult, because you're having to add additional steps, and also there's a lot less options once a patient bill does get to bad debt. So contrasting Florida, went through the Senate and the House, and we've got a lot of information in a bipartisan bill. Maryland is doing some rulemaking in a different fashion through their Health Services Cost Review Commission. Now, the Healthcare Services Cost Review Commission, it is not new. It has been around since I think 1971. Um, what is new is that they did pass through the legislative process requiring that the Health Services Cost Review Commission add more guidelines for the hospitals to implement income-based payment plans that I had mentioned earlier, update additional debt collection rules, and financial assistance rules. These guidelines were published in May 2022. I have linked in the resources the full guide. Um, but what was done there with the Health Services Cost Review Commission, I will say that this group is incredibly engaging. I was really excited to actually see this group at HFMA Annual this year. And I really see a signal from this group and from the healthcare providers Access One does work within Maryland, a very responsive group to try to help health systems meet these policies. But um, since 2022, the guidelines have been revised a few times, but really the two big impacts are listed on this screen when you think about revenue cycle impact. And so hospitals are going to need a cost-effective, scalable way to offer notice and offer payment plans. So in Maryland, it is required that payment plans are offered. Um, Payment plans must be offered to everybody, regardless of income. And for all of these payment plans, the minimum payment cannot exceed 5% of the individual's adjusted monthly income. And these payment plans can bear no interest or fees. What's been really nice about the Healthcare Services Cost Review Commission, Access One has sort of gotten a front row seat in Maryland, partnering with our healthcare providers in Maryland to design, okay, how are we going to collect income? At what point? Who and where are we going to be collecting this income, whether that be a third party source or directly from the patient? And how are we going to set up these payment plans to be compliant? Access One had put together a plan with our Maryland providers and have had it approved with the Health Services Cost Review Commission in conjunction with those healthcare providers. I think what's interesting here in Maryland is if you are a Maryland provider, these guidelines have been around since 2022 and health systems are working on implementing them. What we've heard is that the Attorney General is starting to increase their attention here. We heard from one provider that they received a ping from the Attorney General letting them know that there was a link that was dead on their website. And so the Attorney General is looking for compliance with these rules, an effort to be compliant with these rules. It's very obvious because, especially in Maryland, there's this requirement to post very obviously the payment plans that are offered to patients and how to get those payment plans, but also in addition to all the posting around the financial assistance. Um, And then comparing that, I think now to North Carolina. So this is hot off the press. The North Carolina just recently made a first of its kind, unprecedented change on some of the revenue cycle policies and regulations through a very unique way. So we talked about Florida. your normal, you went through the House and the Senate and did some policy making. In Maryland, we've enabled and empowered a policy organization that had a very robust multi-month process to build policy in conjunction with health systems. And in North Carolina, there has been, for a couple of years, an attempt to pass a law in North Carolina around medical debt and financial assistance, and it has failed historically. In 2023, North Carolina expanded Medicaid, and happily its entry into a federally funded program called the Healthcare Access and Stabilization Program, HAST. And then in the spring of 2024, the North Carolina DHHS got approval to add additional requirements for hospitals in order to receive some incentive portion of these Medicaid dollars. So these requirements require presumptive charity. They require a large amount of debt forgiveness going back to 2014. They're very, very prescriptive rules. We will include them in this presentation because it's something that you'll really want to go through with a fine tooth comb, because it's there are very narrow exceptions and applicability in different areas. But I think, and as of October 2024, all hospitals have signed onto HAS. I think the difference here, however, is we just do not have a lot of information, especially publicly, not being, Access One and me, not being a healthcare provider. There's very little information on the background and intent and the policy making, which makes it incredibly hard for our health systems to navigate these guidelines. The guidelines are, I believe, about 8 pages long, which is not a lot of detail. And so we have Access One, along with its healthcare providers in North Carolina, we're engaged just like we did with Maryland. We are seeking to understand so that we can be ahead of these regulations and help be part of the solution here in North Carolina. But really the impact is going to be pretty substantial, in that hospitals are going to need a cost and effective way to obtain income and household size. There'll need to be a scalable way to administer charity and payment plan programs. And I just think the cost of debt collection activity will continue to increase under these plans. Now, if I look at what happened in Maryland, like I said, these guidelines went through in 2022, and there were many iterations. I think one thing to call out about the FAST program is that it is implemented over a rolling schedule into 2026. So this leaves opportunity for engagement with the Department of Health and Human Services for clarity, for potential revisions of the guidelines. I have spoke with the folks at North Carolina Department of Health and Human Services. They've shared with me there's really no intent to release any additional guidelines in the short term. However, I think that this is where we can lean as leaders to really ask and push for clarification on certain requirements, so that we can, possibly continue to refine these for clarity, so that, as I think everybody, all hospitals have signed on for these additional dollars and want to make some best efforts to comply. I think, just to model back what I want you to take away here, is that this was done through an incentive program for Medicaid. And one thing I'll call out that's different between these 3 states is Florida. You have not expanded Medicaid. And the Biden-Harris administration has shared that they are looking at North Carolina as a model for the country. And so, I know there is a pretty well-funded group in Florida that is planning to get enough signatures to bring Medicaid expansion to the ballot in 2026. And so it will be interesting to see if this model is picked up and used across the country. And so if you're in some of these states that have not expanded Medicaid, and that's not, I mean, it could come to states that already have, but it's something to think about that there are these income requirements. There's a lot more charity care. There's a lot more posting. Again, this will be included in this presentation that you may want to be thinking about if this North Carolina model starts to roll across the country. How are we preparing now? And finally, just to leave time for some questions, we're running into about 15 minutes to go. What do we do here? So, the challenge really is how are we leading through uncertainty? And, coming back from someone who has deep experience in the financial services regulatory regime that we're seeing kind of pulled over and emulated into the healthcare market, what I can tell you time and time again, speaking with regulators on a daily basis, is understanding the why, understanding the intent of some of these policies, because if you can demonstrate that the policies and choices that you have made align with the spirit of the policy making, that usually will go well. Uh, and I think going back to the presentation is where do you find that information? And really it's in digging into the statutes and the policy. And I've included a bunch of resources where you can start digging in and reading the backdrop to where these policies came from. I think second is the challenge is how do you implement policies when you just don't have enough detail? In particular, like I said, in North Carolina, there's just there's not a lot of public information on the why and the interpretation and the position. And so how do you go about applying these policies to a complex healthcare system that just may not be well tailored? And I think the approach to take here that is to start enacting policies that are responsive, but be careful and thoughtful that you're not putting yourself in a position where you cannot be nimble and flexible. The one thing that we do know is that healthcare regulations and healthcare payment regulations are continuing to evolve. So I think one of the challenges in particular is once you sign on to a policy, sometimes it's really hard to change when you have a lot of patients who are maybe you've driven a consumer behavior around expectations. And I think one of the things to go back to like the North Carolina example is that this program could be just funded for a couple years. What happens if those dollars dry up? The local NPR station in North Carolina has said, we're going to have a governor change, which means there could be a lot of change of the different agencies. So you could have a shift or change in the policy. And how do you, not make overly swift reactions to what I would say I love. Our CEO, Mark Spinner, just said it this morning and I loved it. He said, this is weather, not the climate. I wrote that down immediately and it's, we need to plan for the climate and not react to the weather so that we can be nimble along the way. And then I think, how do you navigate the federal and state requirements? And then leaning on your vendor partners. As Joe mentioned, like I am a resource that can dig deeper with you, but also just making sure you're partnering with vendors that are thinking about this, that are partnering with their product teams to make sure that we are developing and providing solutions to healthcare providers to solve the regulatory environment of tomorrow. And we're not playing catch up. I think engaging in your industry trade groups like HFMA or other groups to prioritize covering these regulatory topics. I think there could be great value of people in some of these states getting together to say, how are you solving this? And how can we have a collective voice that is going to our policymakers with the same concerns? Because as I said, at the beginning of the presentation, there's a very tight talk track about how media and certain agencies are painting the healthcare industry, and there just is kind of a lack of cohesiveness on our side. So really engaging in trade groups. And to that end, I will be, if you're a part of the Healthcare Academy, I will be in Arizona in a couple weeks at the Chief Revenue Cycle Forum. And I'm really excited to engage on these topics. So feel free to give me a ping, and we can chat deeper on these topics. And then finally, engagement and advocacy. I'm hearing from a lot of providers that feel paralyzed. Like, oh my gosh, like I have denials. I have all these other things that are going on. And then this whole host of healthcare payments, self-pay regulations. And I'm feeling like I don't want to do anything until the bumps sort of end. Well, I think there's high risk in that. I think there's high risk in not acting towards what I'm saying is enacting and starting to move and make decisions. Because otherwise, doing nothing and not engaging with these policymakers and regulators, or even with your vendor partners, you do not want to be in a position where they're telling you what to do in enforcement. Um, so, additionally, not doing anything is just going to kind of exacerbate the medical debt issue of where if you're just like not doing anything to engage with your patients or not making changes, I think that's actually the worst place you can be. And expecting I think this trend of healthcare regulations is just going to continue and to accelerate. It's going to feel hot during this election season, but is not going to end. So I really encourage you to act in this time. So with that, I think I am just about at time. Joe or James, did we have any questions that were submitted or from the chat?
Hey, KaLynn, it's Joe. I do not see any questions. So as we have about 10 more minutes, if you all have a question, please unmute yourself and ask away.
A question for you. You mentioned early on that if patients use a credit card to pay their medical bill, they may be giving up certain protections. Does that include like an HSA card, or is that a different category?
That's a great question. I would perceive that as a different category. What they're concerned about is if I go and use my traditional credit card, and let's say I then get approved for financial assistance later, um, what sort of harm am I going to have coming from by putting my medical debt on that credit card? And it's about, I'm going to maybe have interest. I will be that balance is going to be reported to the credit bureaus. Whereas like with an HSA card, that's not going to be the case where they're going to be reported to credit bureaus or anything like that. It's being used to cover the medical bills. Additionally, as a policymaker, I think HSAs have seen to sort of solve for that high deductible issue. So I really don't think that they're going to focus on HSAs, and it's really about the use of traditional high interest credit cards on medical debt.
Thank you.
Yeah, and really, right now, that's just in New York, where we're actually seeing a requirement for disclosure, but could show up other places.
KaLynn, we do have a question from the chat. I can either read it to you, or if you see it, I'll let you take it.
Yeah, I see here. Someone's asked, will AccessOne be reaching out to North Carolina hospitals to address new workflow and interest in payment terms being mandated by the state? Yes. So we would love to continue to engage with you to understand what are you doing first in response to North Carolina has. We um, have many clients in North Carolina, and a trend between all of you is that you're standing up committees. And so we would love to get engaged with these committees so that we're working in lockstep to ensure that we're applying the policies when they apply, and understanding that we're also saying the same thing to your patient base as we're saying. So yes, we will. Cindy will absolutely put that down. Well, I appreciate everybody's time here today. As Joe said, this is a lot of information. In the back of this presentation, I have actually included an entire everything I've referenced here today. I have made it easy for you to find so that you can go share this with others in your organization. If you have a government policy or legal team that maybe isn't closely watching this, it is common for me to get engaged with those teams. So I'm happy, client or not, of Access One. This is an important area, and I think I've sort of sat in this very unique niche between healthcare revenue regulations and financial services regulations. So, also, I will be at, as I said, the Healthcare Academy Chief Revenue Cycle Officer Forum. I'll also be at South Carolina HSMA here at the end of the month speaking on this topic. So if you are going to be at that conference, please reach out to Joe or I, and would happy to get coffee and talk more on this. I'd love your perspective because right now I just really have my lens on it as a financial services regulatory attorney. So
Well, great. Thank you so much, KaLynn. Thank you to all that attended PNC and Access One. I'm very appreciative and know that you guys are busy. So please reach out with any additional questions. And again, as I mentioned, we'll reach out to the folks that were looking for some deep dives. So thanks again.